Okay, so I'm blessed, David Daku. I'm a registered general nurse who is the nurse manager, the ward manager of female ward for the past 4 years now.
Past 4 years, okay.
Yeah. Okay, so we have a bed capacity of 44.
44.
But in a year, we can admit close to 1,718 patients.
Oh wow, okay. On this ward alone?
On this ward alone.
Wow, okay. Do you know how many people are working at this ward right now?
Yeah, we are 14.
14.
The main staff we have here, we have 14.
The core.
The core staff.
Okay.
We have 14 nurses. But we have categories of nurses here. We have those who went to the university to study nursing, that's Bachelor of Science. We have those who went to the diploma or the nursing training colleges to study nursing. We have those who have certificates in nursing. So we have 3 categories of nursing here. Nurses here, yeah. So that's it. We have the senior nurses and the junior nurses.
Okay. Are there any specific cases or illnesses or injury that you think or you observe occur more often than others?
Yeah. When you look at the data, it's quantitatively, when you look at the data, most of our cases we've categorized into 5. We have 1 being malaria, 2 being hypertension, 3 being diabetes mellitus, 4 being stroke, and 5 being, let's say, gastroenteritis.
Okay.
So that's it. First is malaria, 2nd hypertension, 3rd diabetes, 4th stroke, and 5th gastroenteritis.
Okay.
Yeah. In Africa, we are in the tropics, and when the rain starts, malaria cases will go up because of the rain. And it depends, starting the year, just after Christmas or just after, let's say, Idul Adha, people report to the ward with gastroenteritis because of the festivities. They end up drinking so much, they end up eating so much. So just after Christmas, people will come with gastroenteritis. Just after any festivities.
Yeah.
In the country, people normally come with gastroenteritis, sometimes enteric fever. But within the year, we most of the time record malaria and also hypertension and diabetes mellitus.
Okay.
Yeah.
The thing I observed here is that you have a lot of DM patients, so diabetes patients.
Yeah.
Is there any reason for that?
Yes. So the trilogy of causes of medical conditions. We have the host, the agent, and the environment. Okay. And blacks are prone to having diabetes mellitus because of the environment. Most of them are obese. Okay, so with the type 2, and we have types of diabetes. We have the gestational, the type 1, which is insulin dependent, and the type 2, which is non-insulin independent. So, and most of the type 2, they are fat. Okay, so our environment, the things that we do in the society normally predispose us to getting diabetes. So as I was saying, diabetes is a trilogy. The host, which is the patient itself, the agent, the disease condition, and the environment where the patient lives. What food does he or she eat?
Yeah.
Okay, all these things predispose someone in getting diabetes.
Okay.
Mellitus.
And that increases.
That does it. Yeah.
To what extent are hospital fees covered by health insurance?
Yeah. So for the fees basically is 100%.
100%.
100%.
Okay.
It's a policy. National Health Insurance is a policy that they have, that if a patient comes to the ward and he or she is insured, okay, then he or she is not supposed to pay anything after discharge or prior to discharge. Okay, but with the medications, sometimes it's not covered by the national insurance.
Okay.
But the fee, maybe after the care or doctor review today, patient is okay, patient can go home. If he or she is insured, then it's free.
Okay.
That is 100% free.
Okay, so the fee is always free, but it depends on the medication.
It depends on the medication.
All right.
Yeah.
Many individuals of the hospital staff have already told me that this hospital could really use some external resources, like, for example, stretchers. In your opinion, what would you say?
Yeah, it's true. We are hard pressed, and you see, it's a demand and supply thing. The demand is so high, but the supply is too low. So what are we supposed to do? We are supposed to do what we call rationing. So, for example, when we had COVID-19, the outbreak, some hospitals were having more than other hospitals. It's the demand and supply chain. Okay, and basically, with my 4 to 5 years experience at the hospital, I've seen that most of the equipment we don't have. For example, the stretchers. Now we have wheelchairs. Okay, the region brought wheelchairs to us last 2 weeks.
Oh wow!
So we are okay now. But when it comes to the stretchers and other things, we are lacking. But it's not a bad thing at all. We've actually made progress on it. Yes, initially it wasn't that okay, but now
it's better.
It's better. The insurance is paying, and people too are coming to our aid. Okay, I quite remember last year we had a Ghanaian who was staying in America came to donate a BP apparatus to us to be used on a patient. So it's not bad. Yeah, we are getting there gradually, and we know that one day everything will be fine.
Okay.
Yeah, everything will be fine.
Is someone coming?
Yes. Yeah, so the pandemic came, as you know, started from China, then went to other countries. Then it finally came to Africa. So Ghana, we recorded, I think, our first case in March, I think last 2 years or so. So when it came, we have to activate the emergency, public health emergencies. And what are these public health emergencies? You make sure people are isolated when they start showing some signs of COVID infection. So what we did was to train, what we do, capacity building. So we train the staff on early detection of COVID-19 within the hospital and within our communities where we find ourselves. So after the training, we establish a team, a protocol COVID-19 team with so many branches. Some were responsible for taking samples, some were responsible for surveillance, some were responsible for contact tracing, and some were responsible for case management. Basically, the doctors were those responsible for that. So after that, we established the holding area. Okay, we should have a place where they can keep them. So we had a holding area. We had one at the female ward where we were holding or were managing cases we suspected to be COVID-19. But it was a national policy that when you see or when you detect, when we treat it. If it becomes so severe, then we refer to the treatment centers. So in East Central Region, we had about 6 treatment centers where ambulance was ready, very available, in case you can't manage it, or maybe you need high pressure oxygen. Then you call the necessary quarters, then they will organize the whole thing, then you will send the patient to the treatment center. So, female ward, we had one holding area where we were managing COVID-19 cases.
But now we kind of closed it, right?
Oh no, it's still there. It's just that we are not recording the cases.
Yeah, I mean, I see the sign is there.
Yeah, it's there. And it's boldly written, holding area.
Okay. You're on this ground. You're not testing, right?
Yeah, we are not testing. But initially we were testing. But as I was saying, there is a chain of command. There is a chain of communication. There is no way I will not be aware if there is any COVID case around. No, there is a chain of command. Okay, so at the OPD, at the triage, when you see someone exhibiting the signs, all you do is you call. So when you call, a team will come. Then the team will assess, then admit the patient to the holding area.
Before someone's even admitted here, they are checked. If there's
checked.
any suspicion,
that's it. Yeah. So they will call you that this is the case that we have at hand. We are bringing her or him to your ward.
All right.
Yeah, then you prepare the place for them.
So all the testing is also done by the specialized team. Then?
Yeah. So as I was saying, it's a team, but it's categorized into sections.
Okay.
Where we have the testing team, the case management, the surveillance, and the contact tracing.
Okay.
So they were actually trained on how to take the COVID samples. So in case you have any suspicion, you just call them, then they will take their sample.
Okay.
Then they will send it to
They have the
Norwegian.
protocol.
That's it, yeah. So that's the protocol. It's a national protocol
Okay, very good.
that we all follow.
Okay.
Yeah.
Because when I first got here, I was wondering why there's no
Oh,
testing.
it's because the country itself is not acknowledging the COVID-19 anymore. Most countries are not.
Mhm.
Yes, and
I see.
but initially when it was so much, the protocols was so severe.
Would you say that there has been a shift in people's opinion about hygiene and health in general
Oh no.
since the pandemic?
No, I won't say that. Even though we are a biopsychosocial being, so when you see a patient, the patient is a biopsychosocial being. There's a research going on that they want to add the spiritual aspect to a patient. So when the patient comes to you, you should also understand his or her spiritual makeup, the church that he goes. Is she a Muslim? Is she a Christian? Is she a Buddhist?
Yeah.
We should all factor all these things together in helping the patient to attain maximum health.
Yeah.
Okay, so initially, at first, people were not coming to the hospital. People were doing their own thing. The perception wasn't good. They were going to soothsayers, herbalists, but now they are coming to the hospital. And we did a client satisfaction survey. That was this year. We did a client satisfaction survey, and about 90% of the patient that we see or that we cared for wanted to come back to the hospital again if there is any such problem. So the awareness has increased. Initially it wasn't okay, but now it's okay. Yeah, people are going more into the orthodox way of caring.
Okay, so that has increased.
Yeah, that has increased.
Is also connected to something many people told me, that some people prefer going to their local traditionalist herbalist before going to the hospital.
Yeah, and that's their belief. That's what they believe. And you see, we have a traditional herbal medicine enclave now. We have institutions that are regulating the herbal medicine in Ghana. And now we have a herbal doctor. Initially, they had perception about the orthodox medicines, that prolonged usage of the orthodox medicines will probably even predispose you to having liver failure, kidney failures, and other things.
Wow.
But because of the sensitization, we go to the community, we go to the churches, we go to the mosques, we go to the villages, we educate them, and they have realized the effectiveness of coming to the hospital. Initially, when someone, we had a condition called Ludwig angina. It's a infection of the teeth.
Yeah.
Okay, that's the bad state. But normally it starts with dental caries, okay, the dental alveolar abscess. Most of them will go to a community called Buakwa. Okay, there's a community like that, Buakwa, where they believe that there is a man there who can heal them. Okay, so they were going there. Some of them were ending up in a men's state. So those who ended up in a men's state came to the hospital and were able to save their lives. So they also went back to the communities and they were preaching a good gospel to them. So that, in other way, helped us to actually avert such complications. Okay, so most of them were coming to the hospital.
People educate themselves.
That's it. So we were doing that more often. And for me, the awareness has increased, because when you even look at our admissions and look at OPD attendance, it goes high every day. Okay. That's it. When you do the correlation,
you can really see it in the data.
That's it. It goes high all the time. So it means that people are patronizing it. Yeah.
About the education program,
that's it.
Some of my friends had questions about sex education in general. Are there any?
In Ghana, we hardly do that. It's because of the fabric of our community. Even parents don't even educate their children on sex education. So it's a whole thing. But we thank God that our Minister of Education now, the curricula Okay, they've actually factored in education.
Some people said that there's a big issue of, for example, teen pregnancy in Ghana.
Yeah.
Or also STDs, STIs.
Yeah, that one cuts across. When you even go to Guatemala, is the teenage pregnancies everywhere, but is their prevalence. Okay, initially it was so high, but now because of, as I was saying, targeted education and going back to the communities through the chiefs and opinion leaders, that one has kept the situation for us.
Okay, so the hospital itself is not involved in any.
Oh, we are involved in that. We have the adolescent unit at the X-ray department. We have the public health unit. We have the reproductive and child health unit. So they go to the radio and talk about their products.
In Germany, the media coverage of African countries is often very one-sided and often fails to paint a picture of the real situation in one country. So, as the end of this interview, would you have something you want to say to the people who watch this video in particular?
Yes, there is one simple thing I want them to understand. We are Africans, and no matter what, we are all parts of the society. We are all trying to make a good future from. We have issues because of maybe one, our political leaders who are leading us. Per se, Ghana is not a bad country at all. We are actually making progress. Now we have the telehealth being introduced. We have the telehealth. We have drones delivering blood products and medications to our rural folks. Yeah, the perception out there is so bad, but we wish to erase our perception. We are very welcoming. We are very warm. We are not that cold. It's never true that we are so much hard on gays and lesbians. It's not true. We are a loving country, and we wish to build a strong foundation as human beings and the proper way of doing things as human beings. That's what I want to say.
Okay. Thank you very much.
You're welcome.